All right. Good evening, everyone, and welcome to today's Thriving Dentist Expert Panel. Trust-based case acceptance, turning treatment plans into shared decisions. My name is Angie, and I'll be your host for today's discussion. We're excited to have three fantastic experts joining us to share their insights on building trust with patients, improving case acceptance, and creating treatment conversations that feel collaborative rather than transactional. Now, before we get started, just a couple of housekeeping notes. Today's session is being recorded and you'll receive access to the replay afterwards. We also encourage you to participate throughout the discussion. Feel free to drop your comments and thoughts into the chat. And if you have questions for our panelists, please use the Q&A feature. To get things started, let us know where you're joining us from in the chat. We'd love to see where everyone is tuning in from today. All right, so before we jump into today's discussion, I want to quickly touch on an important point highlighted on this slide. So many practices are generating inquiries, but not all of those inquiries are turning into booked appointments. Sometimes the challenge isn't clinical expertise. It's attracting the right patients, building trust early, and making it easy for people to take the next step. That connects perfectly with today's conversation because trust-based case acceptance doesn't begin in the treatment room. It often starts long before the patient ever walks through your doors. Today, we're going to explore 5 key areas. First, why traditional case presentation methods can sometimes work against trust. Second, the psychology behind how patients make treatment decisions. Third, how to shift from a one-way presentation into a genuine two-way conversation. Fourth, the role of the entire team plays in supporting case acceptance. And finally, how to measure success without turning case acceptance into a sales metric. So our goal today is to share practical ideas and strategies that attendees can take back and implement in their practices right away. Our first panelist is Janet Hagerman. Janet is a fractional CHO and case acceptance coach who helps dental practices and DSOs improve patient-centered case acceptance, strengthen hygiene departments, and build systems that support sustainable growth. With experience as a clinician, consultant, coach, and hygiene department leader, Janet has helped practices improve both patient experience and treatment acceptance through relationship-based communication and team development. Janet, we're really excited to have you with us today.
Thank you. I'm delighted to be here.
Joining us next is Rika Markel. Rika is the founder of Mindful Dentistry and brings nearly 4 decades of healthcare experience, including many years leading multi-specialty dental practices. She is the creator of the Mindful Dentistry method and has dedicated her work to helping practices move away from pressure-based conversations and towards trust-based communication that helps patients feel understood, comfortable, and confident in their decisions. Thank you for joining us, Rika.
Thank you so much. I'm so happy to be here.
Our final panelist is Dr. Andrew Firgaira. Dr. Firgaira is the founder and principal dentist of Oasis Dental Group and has built the organization into a successful multi-location practice while maintaining a strong focus on complex and outcome-driven dentistry. With advanced training in implant dentistry and extensive experience in comprehensive treatment planning, he brings valuable insight into helping patients navigate significant treatment decisions with confidence. Andrew, thank you so much for being here today.
Thank you for having me. I look forward to it.
All right, let's get into the main discussion. Janet, I'd love to start with you because you worked with so many teams on this. So a lot of practices were taught a fairly traditional present and close approach to treatment conversations, What are some of the early signs that approach is actually damaging trust before a patient has even made a decision?
Well, presenting and closing the case are two things that come really towards the end of the appointment. And we like to really get away from focusing on that because the whole concept of case acceptance involves the entire appointment from the beginning to the end. Everybody needs to be included and everybody has a place and a position there to help develop rapport and relationships with the patient. So in our country, in the United States, case acceptance is only 30 to 50%. So we know that what we've been doing in the past has apparently not been working very well. So it is a all team effort. It's something that needs to be trained regularly because we know that in any kind of learning, adult learning included, repetition is what helps us remember. So it's everything from how the patient is greeted when they first call on the phone before they even have an appointment. What's the conversation they have with the front desk? What does that sound like? Does that make them feel welcome? When they come in, when they're greeted, how the hygiene appointment goes, how that experience goes, the experience with the other assistants, with the doctor, what all those different handoffs sound like. So it really has a lot to do with communication skills. So, we spend most of our time in today's society, all around the world, communicating on our cell phones, our devices with emojis, and then we expect, our employees to sit down and have these in-depth conversations with patients about something as personal and important as their mouth and their pocketbook. So it's something that we should be committing to regular training, what those communications should sound like, and also asking good open-ended questions and not talking so much. I think that's one of the biggest problems that we have is we talk too much and then we get to that present and close and wonder why that doesn't happen because the building blocks haven't been set up appropriately before that.
I think that's such an important distinction. Rika, building on that idea, I'd love to talk about pressure. So many teams have good intentions, but patients can still walk away feeling uncomfortable. Where do you think pressure first shows up in the conversation?
Well, I think in the patient's mind, even before they make the appointment, because as far as I'm concerned, most patients don't want to go to the dentist. That's something that they push forward. They don't want to do that because they're afraid. And they're afraid for two reasons. They are afraid for the pain and all the things that they had to endure when they were younger. And I'm talking for my generation, but also the generations after me. And so afraid of the dentist, that's what's playing in their head. So that's already something that we have to take into consideration. When somebody makes the appointment, we have to be very sensitive to that, mindful. That's why I always talk about mindful dentistry. If we are mindful and we also think about how we want to be approached, like in a state of fear, when you're not so comfortable making that decision, then that should be that's the first thing, like understanding what is going on in the patient's mind when they make the appointment, because that's the first hurdle that you have to overcome.
What can a clinician do in the moment if they sense a patient is pulling away?
Well, that's a long answer. So I think one of the main things that I see happening is that usually a clinician or a doctor, hygienist, or whoever comes in touch with the patient, they have their own agenda. They're thinking about what they have to do. And it doesn't matter. Like the front desk, they want to make sure that they make the appointment at the correct time and that the insurances are verified. They have their own agenda. And then you come into in the back, and the dental assistant, they have their own agenda because they want to make sure that they do everything that the doctor needs to that they need to do for the doctor. So when we're very occupied with our own needs when it comes to patients, the same for the doctor. They think about, how am I going to treat this patient? What do they need? I'm not saying that we don't do that in the best interest of the patient, but we're very self-absorbed. So the first thing I would say is you have to really, again, be mindful and put yourself in the shoes of the patient and get your own your whatever you are thinking, your needs out of the way so that you can attend the needs of the patient.
I think that's something a lot of practices can really relate to. Andrew, patients today often arrive having done their own research. They've read their own reviews, watched videos, or even received advice from social media. How has that changed the way you approach complex treatment conversations?
I actually find that patients who arrive well informed are probably the easiest types of patients to deal with.
Mm.
I guess with where my practice has gone over the years, so I started from treating and seeing every type of new patient that came through, and in those situations you're dealing with a different type of patient where if they come in with extensive need, they often don't understand that yet. And so that's a whole different pathway to slowly co-discover and go through a process where they see and understand their problems and actually want a solution. Whereas these days, I find that I'm in a fortunate position where I've got patients who are seeking me because they already know they have extensive issues. They've now picked a treatment pathway because my area these days is full arch implants. But as I said, we've got a group that I work with as well. So they come in thinking this is what they need. So my role now is to sit with them, listen to them, find out what their actual desired treatment outcome is. So not to just pigeonhole them into this one treatment because that's what they think they need because they've done all the research, but simply to find out what is it that they need or that they're seeking as a treatment outcome, help them to understand where they are, and then provide those solutions that could be something like a full arch, but it could be a more regular complex rehab as well, where we're actually maintaining and keeping teeth. So the moment they understand that you're in a position to help guide them, you're there to help look after what it is that's actually concerning them, as opposed to trying to just fit them into a category and just have them, go through a production line. When they understand that you're listening to them and you're there to help them, that actually makes it a lot easier than cases where you need them to actually understand the problem in the first place.
Have you found patients are looking for something different today compared to maybe 10 years ago?
For me, it's probably more so just the evolution in where my practice is over time. So I specifically have patients who seek a particular type of treatment from me because that is what I personally provide. But in terms of patients who come through the group as a whole, I think you've still got the full spectrum. So you've got patients who are very well researched, and you've got patients who come in just wanting a checkup, thinking there are no issues whatsoever. And again, they're two very different treatment pathways. But the fact that there's a lot of information out there these days regarding different types of treatment, I find that actually, in most cases, helps to guide that discussion because it's easy to lean on what they've already learned.
Perfect. Janet, I'd like to say on a theme of trust for a moment. So many practices are under pressure to keep schedules moving and encouraging same-day treatment whenever possible. So how do teams balance efficiency with meaningful patient dialogue when time is limited?
Well, productive scheduling comes first. So we need to be, I mean, I'm a big fan of block scheduling where we have high production, low production procedures in place and places for emergencies, things like that. When we say pressure to do same day treatment, it depends on what it is. We definitely want to maximize. I prefer to think of it as maximizing the schedule. We definitely want to maximize the schedule. We want to take care of patients who have immediate severe needs. And we also want to maximize the timing for the patient. If they can get 2 procedures done instead of one at a time. We want to do as much as we can in the time that we have for the patient. But again, all that has to do with planning at the beginning, knowing every person's place, what their conversation should be with the patient, and what that looks like. So a practical example of that is the morning huddles, looking at the schedule and saying, do we have opportunities to move somebody over, or if it's in hygiene and we find they have a need, can we move them over to the doctor's side, and vice versa. So planning ahead, really maximizing those early morning huddles, knowing the patient's needs, and knowing what every person's place is in terms of the conversations that we have with our patients, helping them to feel understood. We know from studies that the two major things patients want is they want to feel like they have a relationship with their provider, and they want to feel like they're part of the plan. So, long gone are the days where you just, whatever the doctor said. Patients now want to feel like they have a part of that. And whether it's doctor or hygiene, that's a great opportunity once you invite the patient into the conversation and help guide them to the decisions that are in their best interest. You get a much more compliant patient, a patient who keeps their appointments, a happier patient and a loyal patient. So making use of that same day treatment, that's important. And it has to do with scheduling, and it has to do with communication throughout the whole team.
All right, that's a great reminder. Rika, let's build on that for a bit. Before a patient can confidently move forward with treatment, they need to feel heard and understood. So, how can clinicians tell whether a patient truly feels heard before discussing recommendations?
Well, I think that most dentists and hygienists, they can feel already. They sense they have enough experience to know when a patient is like closed off and when nothing's gonna go well. And I just want to also build a little bit of what Janet just said, because we are very, very rigid sometimes. And I know that I know Janet, and we spoke already in length, so we are very, very close in how we do things. But sometimes, like, we want to set up those procedures, we want to set up those blocks, we want to have same day treatment, but we cannot forget that we have to be flexible. And sometimes it is important that our team understands that even though there are rules, the rules are there to break if it's in the best interest of the patient. So you need to find that balance between this is how we do things, again, our own best interest, and this is what the patient needs. And so we have to bring those two together. And that is a challenge. That is a challenge to really be so, and I'm sorry to say the word again, to be so mindful that we feel what the patient needs. And it's not always, sometimes we have to have the courage to say, we're not going to do it today because our patient is not ready. We feel that there is still something that is not completely out of the way. And I think a patient can only say yes to treatment when they feel safe. And safe means it's not safe in the way that we think safe, like we can make the whole thing safe. But if they are in fight or flight, if they have all those hormones like running through their veins, there is not even, they will say yes, 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 but inside they're screaming. And so that is the art. We have to figure it out. How do people feel? What is it that's going on? What's really going on? Because this is where patients don't show up for their appointment. They will say yes, yes, they sign everything, they do, they come, and then they don't show up. Why? Because we didn't do a good job by listening, by really tuning in to what the patient is feeling at the moment. And sometimes, and I want to go already, like I would love to know Andrew's opinion about that, because if you have those very invasive treatment plans, patients are not going to say yes just over the front, like over the desk and then sign the papers. There is a process. There is like, we have to be a little bit more patient. Like sometimes it takes, in my opinion, when I would work with patients with really like very expensive treatment plans, it takes 4 or 5 appointments to sit with people, to go over it, to take all their fear away, to make them comfortable, to build that relationship. And once you do that work up front, you'll see afterwards you have no problems anymore. The patient will come in on time, they will be ready, the money will be paid, everything will be fine if you do that work up front, if you don't try to push them into your box. So that's just my what I saw happening over the years. And I would love to know what Andrew has to say about that.
No, I think there's some really good points there. And I think it varies depending on, how the patient arrives, because you've got to understand, like a patient who comes in not understanding they need much treatment, but there is, significant issues going on. You typically, and I think this is moving into actually the next question anyway. So I don't know if you wanted to mention what the next question was, but it had to do with presenting, the full claim, right? And or pacing treatment when affordability limits readiness, I think it was. So it's completely aligned with that, in that it's important that we provide a full diagnosis, but we need to do that in a way where the patient understands. So we're not just telling them you've got these problems. So you go through a co-discovery, they see those problems, they agree there's those problems, and you typically have, on average, it's quite simple for an experienced clinician to narrow it down to 3 choices, really. The first choice is no treatment and the consequences and outcomes of no treatment, because doing nothing is a choice, right? And the patient has the option to take that and to say yes to that and to accept the consequences of where things move from there. The second might be a stabilization or entry-level treatment, which is at least going to get them out of their most difficult and fundamental issues, buy them time, make things better to a certain degree. And then the third would be a complex rehab. So treating everything to, call it a gold standard. Now, there's obviously a whole spectrum in between that, but understanding those 3 sort of areas helps a patient to know where they are, what the problems are, what the different outcomes they are, and the different price ranges in there. And then they can start to even choose and pick, like, what do I want to be smack bang in the middle? Do I want to do this, but actually move a little bit further towards ideal, but I can't quite afford that? So we're really just making the process easier for them to say yes to whatever they choose. So they're not just being presented that you need this treatment and this is what you're going to have, and start to feel pressure and go down that pathway, like you said, where they're saying yes and just inside running out the door and trying to find a way to get out. We're giving them the opportunity to choose what it is that they're after, and then we support them with whatever choice they make from there.
Yeah.
Rika, getting back to you for a little bit, one of the things that you said really interested me. The rules are there to break if it's the best interest of the patient. I think that's something many practices can maybe try and keep in their minds. Andrew, if you don't mind, can you walk us through how that conversation might sound in a real patient interaction?
So if we're talking about a patient who's, again, we're first finding out that they have a problem versus a patient who's coming in already aware that they have an issue. So these days, I mostly deal with patients who are coming in aware they've got a significant issue. But if we're looking at, would you prefer to discuss the version where they come in not being aware, or the patient who already has a good understanding of their problems?
Why don't we do both, if you don't mind?
No worries. I might need a little bit longer for these. So if we start with a patient who comes in already aware that they've got quite a significant issue. So these are patients seeking, let's call it full arch implant dentistry, right? So they've come in, they've found us through whatever material it might be. They've got a very good understanding that their mouth is not in a good condition. Most of these patients come in and they're at a point in their treatment journey where they're just wanting a bit of hope and a solution to find out if I can even have this treatment. So they've often lost hope. They haven't been in for years or even decades, and they're coming in thinking this is the only thing that they might be able to get, if they can even get that at all, because they've heard stories where maybe their condition is too far gone. Maybe I don't have enough bone left. Maybe I can't even do this. So with those patients, it's a matter of us obviously going through a process of getting them in, spending some time with them, listening to what their concerns, their story. So finding out who they are, what's gotten them to that point in time, what their concerns are, and what their final outcomes are that they'd like to see. And from there, we go through that the common theme with each patient is that sort of co-discovery of what they actually have. So I'll go through the records with them on the spot in the appointment. I'll discuss with them how full arch implants work. I'll show them the different options we've got. I'll start to plan implant positions to see what's possible and start to provide them some hope that this might be a solution. Or if they're a case where they've actually got much better teeth than they realized and they're too early in their dental cycle to go down that pathway, I'll start to be presenting to them the much more conservative treatment pathways, which are going to be more suitable for them. And again, giving them that additional hope that things aren't even as bad as I thought. I've been so worried all this time, but they can actually help me. I've looked at this solution that's going to cost me, $25,000, whatever it might be. And now they're telling me that they've got an option here, which is actually much less than that and is going to give me a better outcome. So the big key with it always is finding out, the patient story. What is it that they're after? What's going to mean a successful outcome for them? And then helping to go through with them to give them the solutions from that point.
Is there anything Rika or Janet would like to add into that conversation?
Yeah, what I loved is the word hope that Andrew kept bringing up, because I think when our patients come to us, I mean, like Rika talked about, most people do not want to go to the dentist. They're fearful, or at least they're anticipating that it won't be pleasant. And they often find either they anticipate or they are surprised to find treatment that they had no idea that they needed. And I think just the idea of giving people hope that, you know what, you may have not been to the dentist in a very long time, but you know what, you're in the right place and we're here to help you, and you're in good hands. So let's have that conversation. I think that hope and opening up, also asking a lot of good, Andrew touched on it when he talked about the co-discovery process. We talk so much, like Rika was saying, we talk about where we're coming from, but what we really need to do is meet the patient where they're coming from. So by asking good open-ended questions to find out where that patient is, it's going to help me determine how I present treatment. I'll present treatment, the same treatment exactly, differently based on what that person's values are. So I think asking good questions, that co-discovery process, getting to know people, and giving them hope, just letting them know that you're in the right place. You're not the first person that we've seen like this. I'm sure we won't be the last. We know how you feel. Other people have felt the same way, and what they found was, we were able to help them have a healthy mouth and a healthier, happy life. So I think that word hope that really struck me. I think that's important.
Mm-hmm. Rika, anything you'd like to add as well?
Well, I same as Janet, but I think that the whole thing that Andrew is talking about, co-discovery, that's for me very important, because we sometimes forget where the patient is, or we don't even think about it. Was a big lesson for me. Like, never assume that people know, never assume that they can't afford it, never assume anything, because that's something that it's easy for us to do so. Oh, didn't go to the dentist, definitely whatever. We have judgment. And so I think we have to start with a clean slate and really do that co-discovery process. Like, we have to discover what the patient knows, and they have to discover what they don't know, So it's like you have to walk the way together.
Mm-hmm. All right, so those have been some fantastic insights so far. We've talked about trust, communication, patient psychology, and creating conversations that help patients move forward with confidence. So before we move into the second half of our discussion, I'd like to take quick moment to share something valuable with everyone joining us today. So we've spent the last 30 minutes talking about trust, communication, patient experience, and creating treatment conversations that help patients feel confident in their decisions. But even when you have those systems in place, there's still an important question. Are the right patients finding your practice in the first place? Many practices are excellent clinically, but they struggle to attract enough of the right patients, generate consistent growth, or turn online interest into booked appointments. That's why we'd like to offer everyone attending today a complimentary practice growth session valued at $900. This is a gift from the founder of today's Thriving Dentist Expert Panel, Narain Aruraja. Narain is the founder and CEO of Echo Marketing, a digital marketing company that has been helping dentists grow their practices for many years. So during this complimentary session, you'll receive a personalized review of your practice and identify opportunities to improve patient acquisition, strengthen retention and referrals, increase online visibility, and uncover areas that may be limiting growth. You'll also receive a practical recommendation that can help you attract more of the right patients and build a stronger foundation for long-term success. So to claim your complimentary practice growth session, all you have to do is just simply scan the QR code on your screen or click the link that is in the chat. Once again, the session is completely complimentary, but availability is limited. So if you're interested, I really, really do encourage you to reserve your spot while it's available. So I'm going to give you a few minutes or a few seconds for you to scan the QR code and book your complimentary session. All right, let's jump back into the discussion. Janet, let's start with you. So throughout today's conversation, we've talked a lot about trust and communication as well. So one area where practices often struggle is the transition between the clinical conversation and the financial conversation. So when a patient moves from one to the other, what information should travel with them to help maintain trust and continuity?
Great question. Yes. That's what accounts for, we call that patient amnesia when they go from the clinical area up to the front. So the patient should never be left to do that on their own. They should always be escorted. So the basics are reintroducing the patient, reminding of each other's names, what the patient's there for, what their needs are, and something personal about the patient. So I might come up and say, Angie, here's my patient, Rika. You know, she was in today, as you know, for her cleaning. But as we looked at the x-rays, we discovered a couple of cavities, and we also discovered that one tooth we've been watching for so long, we're going to go ahead and do a crown on that. So, and the other good thing is, Rika's daughter's getting married in a couple of months, so she wants to make sure she has all her work done in time for that. So just something to make the patient so that you feel comfortable knowing that you have the information, even though you should already have it in the computer. And then my patient feels comfortable being handed off from the back to the front. They should already feel comfortable. If I've done my job as the assistant or the doctor or the hygienist, giving them the information, and we've had a conversation that ends up in some sort of agreement about what they want to do and how we can help them do that, then they should arrive to the front already prepared to have that financial conversation. You shouldn't have to talk them into it. You shouldn't have to. There should be no surprises. That's the worst thing that can happen is uncertainty and surprises. So if we can let our patients know where they're going, what they're there for, and then what we've done, and just keep them apprised of every step. That contributes to the certainty that they need to feel when they're in our practice.
Mhm. Is there any chance you can share an example of a handoff you've seen that worked particularly well?
That what?
So would you be able to share an example of a handoff you've seen that worked particularly well?
Absolutely. So it would sound something like office manager Joanne. I just had this appointment with Rika, my patient, and she's ready to check out. I want you to know that she's going to be needing some scaling and root planing. We discovered that, and she understands the need for that. That it'd be 2 appointments for that. And also, just to let you know, she's getting ready to go on a trip. So if you could please help her find some appointment times that would work with her schedule, that would be great.
Thank you so much, Janet, for that. Rika, I'd like to stay with patient experience for a moment. Can you share an example of language that sounds perfectly reasonable to a dental team, but maybe actually make a patient feel managed, pressured, or uncomfortable?
That's again a very interesting question because I think I am known for being the non-script queen. I don't believe in scripts. I don't believe in teaching people what to say. What I do believe is teaching people, and it's not even teaching, I believe in people being authentic and giving them the freedom to show themselves who they really are. And of course, it has to be professional and it has to be again, in that certain box. But I think if you give people words that are not their words, that it sounds very awkward and that patients feel that they're not authentic. A patient that is surrounded by people that are fake, they just want to run. They want to run. So for me, it's more important that staff members are just authentic, that they are who they are, and they treat patients as if they are their family members, their sister, their mother, their brother. I don't care. But some people will be more chatty and other people will be more quiet, and that's okay. So
Mm-mm.
just be who you are as long as you come from a place in your heart to serve the patient, because that's the only thing that patients need. They don't need like sophisticated words. They just want to feel heard and seen and valued and understood. So for me, I never believed in scripts. And that's probably because I can't do scripts either. I couldn't even remember them if I tried to. And if you would, I could never do that. Um, and that's why I never asked anybody to learn anything or to say things a certain way. And again, it has to be professional and we're not going all the other side. I want to say it with 2 words.
Yeah.
But so for me, it is just important that people can be themselves. The patients, my staff, me, the doctors, everybody. And then I think you create like a very coherent and like I love to talk about heart-brain coherence, which means that you have people that are in a very coherent state, no anxiety, no hormones running around. And that's when I think everybody's at their best.
Mm-hmm. Are there certain phrases you hear repeatedly that immediately raise a red flag for you?
For me, for example, when they like, and again, I know it is done a lot. Like when they would say, they would call patients say, "Oh, we just had an opening in the schedule, and you still have an open treatment, and we can bring you in." For me, if they would do that to me, for your convenience, I can come in. I'm sorry, I'm not gonna do that. So I don't do well with that. So I assume that other people wouldn't do well with that. So if you want to, it's again about us. We have a spot available, so now you can fit in. For me, when you want to bring people in, I would call them up and I would say, we had that conversation. Is there anything else that I can help you with? Is there anything that came up? You went home, you probably were talking to your spouse. You have any questions? Is there anything I can help you with? And if you do that at the end of a conversation, when people really are ready to say, when can I come in? And I'm waiting for that. I'm waiting for that question. When can I come in? And I promise you, most people, when you bring them to that place, they want to come in and they want to come in as soon as possible. And the whole thing, like they will ask you, when can I come in? And that's when they're ready.
Andrew, I'd really like to bring you into this conversation as well. Have you seen this come up in treatment conversations as well?
Can you just explain exactly what you're referring to in that? So in regards to the patients wanting to come in for appointments?
If patients, patients are feeling managed, pressured, or uncomfortable.
I think typically that's gonna happen if they don't feel heard. I think that's all it comes down to. So when a patient feels like you've listened to them and there's no agenda there's no pressure, you're really helping them to just understand where they are, what their options are, and giving them the opportunity to make a choice, that whole managed feeling disappears. Because they're the ones making that choice. They're choosing a pathway that's suitable. And we recognize that choosing no treatment at that time might be suitable. That patient might have a reason where they say, I actually don't want to do the middle treatment. I want to do the better treatment. I feel that I can save up for that, or I can do this. And they might actually then walk out saying, I don't want to start anything yet, but I do want to sort of move forward at some stage, and give you permission to then contact them and follow them up at a later point in time. So it's all about having that patient permission to see where is the relationship and what is the next stage. But it's the patient should always guide that as well.
All right, so let's get into the next question. So, Andrew, when discussing treatment options, patients often have concerns, priorities, financial considerations, and questions all happening at once. So, at what point should options, risks, and patient priorities enter the conversation before treatment sequencing is discussed?
Patient priority has to be number one, because if we don't know what it is that they're wanting as an outcome, our solution is going to miss the mark, full stop. So we start with what it is that they're hoping to achieve, what success would look like from their perspective. So understanding what their concerns are, what outcome they want. And then from that point, we move through the diagnostic process, and like we discussed, the co-discovery, before then going through and working out with them the different pathways they can choose. And what I like to do when we're looking at those pathways, like I said, if we're simplifying it to the 3 pathways, is to very simply sort of give some ballpark figures as well regarding short and long-term costs of those types of treatment pathways, so that they also feel that there's nothing hidden as well, in case the patient isn't aware of what the costs of different treatments are, and they can then start to move themselves into whichever pathway they prefer. And that's where we can then start to create the sequence for that. And then as we've done that with them, we can check in again and say, so this is what we've discussed, this is where we're at, this is the solution that you're looking towards, and it'll take approximately this amount of time, visits, and this sort of cost. Is that something that sounds like you'd like to proceed with, or is that something that would result in a successful outcome for you? And if at that point, yes, they've selected and agreed, well, then that you've got your sequence defined from there.
All right. Janet, for practices that are actively coaching their teams, what tells you those conversations are genuinely improving beyond just looking at the numbers?
For case acceptance?
Mm-hmm.
I think the biggest thing for me is, are people talking a lot, or are they asking good open-ended questions? That to me would be the ticket. But Andrew Carnegie said, the guy that wrote How to Win Friends and Influence People like 70 years ago, and it's still a popular book today because his techniques work in about establishing and maintaining rapport and relationships with people. So he said it's better to be interested than interesting.
Mm-hmm.
Better be interested in our patients than be telling them all the wonderful things that we can do for them. Better to find out. And the other thing that's interesting that goes along with this is marketing studies show that people make buying decisions, all kinds of buying decisions, not just dentistry, but including dentistry. People make buying decisions with their emotion. And then they rationalize it with logic. So in dentistry, our brain is divided into the left and the right side. We have the logical side of our brain and the emotional side. So in dentistry, I mean, we live in a world of logic in this little black hole of millimeters. And so when we come to try to explain something to a patient, it is understandable that we would come from a very logical perspective. And that's not what our patients need. Our patients need empathy, emotional empathy. So that's why I teach in my selling dentistry courses how to establish that relationship early on. And it's by asking good, open-ended questions. And by that, I mean questions that cannot be answered with a yes or no. So what's most important to you about your teeth? What's most important to you about your dental practice that you choose? What do you know about periodontal disease? What do you know about implants? So to get the patient talking about their needs and their values, so then we begin to have a relationship. So I can relate to their values, and it's not just all about me telling. So if you were to ask me, yeah, what if you went into a practice other than the numbers, looking, is our case acceptance up? Is it down? Where is it? But just listening to people talking, I would say I would want to hear some good open-ended questions, getting to know the patient's values.
Mm-hmm. We have a few questions that are in our chat. So we'll get to each and every one of you during our Q&A session. So Janet, getting back to you again, if you walked into a practice tomorrow, right, and knew nothing about their numbers, what would tell you they had a strong case acceptance culture?
I would have to say the same answer. Are they asking more than telling?
Mm-hmm.
It said, Walter Haley said, if you want to sell, ask, don't tell. Ask good, open-ended questions and get to know. That's the best way to get to know people. Ask them, they'll tell you. So I would have to say it's the same. It's the same answer.
All right. Rika, let's talk about something that many teams struggle with. A patient says not yet or decides not to move forward immediately. How can teams tell the difference between supportive follow-up and follow-up that starts to feel like pressure?
The fact that they say not yet, I think that's already very sophisticated, because not yet means I'm not ready yet, but doesn't mean no. So that is already like one step ahead of patients just walking out and not even wanting to deal with it. In my own experience, I never had people like saying to me, I don't want to do the treatment, or I am not interested in doing anything. And it is just like Andrew said, not doing anything today is a decision and can be a good decision depending on the case and what's going on. And so I never see patients not doing yet the treatment as a rejection. It is not like they don't want to do it. Like I hear it all the time. Oh, they don't want to do it. That's probably not true. It's oversimplification. So I think that again, listening, what Janet says, like listening and really asking. So what needs to happen for you to want to move forward with the treatment? and listen to what they say. Like sometimes they say we don't think we need it, although I never heard that, to be honest. When a, when a doctor is diagnosing treatment, that's what this patient needs, you know. There is a problem and they need the treatment. So there is no such thing as like not yet means we have to be better. We have to explain to people why it's important for their health. We have to also emphasize that the oral health is way more important than what they think it is. It's influencing their overall health. So it's our job to really make sure that people understand what they're looking at. And most people don't know, and we cannot just think that if they say I don't want to do the treatment, it means that we didn't do a good job enough to really understand where they're coming from, what they're looking for, what their needs are. There's nobody who is going to reject becoming healthier. Then there is an underlying issue. They're afraid of the cost, they're afraid of the pain, they're afraid of whatever it is that goes on in their mind. So we really have to figure it out.
Mm-hmm.
The step is to figure it out. Sure.
Yeah, I love what you had to say, Rika, about that. Not yet. I think that it's our responsibility to keep the patient in our family.
Yeah.
So if the patient says no, not yet, they may not be ready. And as Andrew was saying, you know, the 3 levels of I'm not interested, or I might be interested, but I don't know if I'm ready, or yeah, I'll take the whole thing. So if we can keep our patients in our recare, which is why recare is so important, keep them coming in so all the different team members can continue to support the treatment plan that the doctor has diagnosed, and little by little help that patient feel more comfortable, feel more like they're part of our dental family, and feel more certain and comfortable about getting the treatment. And it may just simply a matter of it's just when I can afford it. You know what? We're here for you. In the meantime, let's do what we can to maintain what you have. But I think it's just real important for the patient to know that because because they cannot afford whatever treatment they need. And let's face it, they come to us for our expert advice. That's why they come. Like Andrew said, a lot of his patients, they already know they need something. They just don't know exactly what it is, but they know they need help. So they come to us for our expert opinion. And if it's something that they can't handle at that point in time, the very least that we can do is welcome them with open arms and keep them in our dental family to continue to support them in their oral health, whatever path that might lead to.
Yeah. Keep our judgments to ourselves. Don't judge anybody, because you don't know what you don't know. You don't know why this patient reacts the way they do. I had a patient that was convinced that he could not afford the treatment. And after speaking with him for a couple of appointments, he decided to stop smoking. And we calculated how much that would be. And in a year, he could do the treatment. And we worked together and we stayed in contact and we were touching base all the time. And he came in and he was like, I already have whatever. And it was like so much, it was amazing. And that is what warms my heart. Like when you can help people, it every time it makes me emotional, because you see, we can help people to smile again, to eat again, to become confident, to have to smile. For you don't understand sometimes how ashamed that people are and how hard it is for them to open up and to come to us and to say, this is my mouth. And they sometimes they really also need our emotional support. It's not always that simple. And I think what Janet spoke about, left and right brain, a dentist or a clinician, not only a dentist, every clinician is very left brain, and they should be, because they have to use that left brain to do the treatment. But they also have to have the capacity to go in their right brain when they communicate with the patient, so that they can be on the same level, because the patient is in their right brain from the minute they step in until you start talking about money, then it becomes a different story. But I mean, we have to have compassion and be very like not and don't judge. Don't judge. I saw miracle stories and beautiful, beautiful stories. That's what inspires me.
That is absolutely beautiful. Thank you so much, Rika, for that. Andrew, I'd like to finish our main discussion with a measurement question. So, for practices presenting complex treatment plans, what metric or indicator best helps identify where patients are losing momentum or commitment?
Look, that's an interesting question. I think that the most important thing is keeping them engaged. So when we've got complex treatment, if the patient feels heard and they feel like they trust you, you've listened, and that you've gone through like I said, the range of options available to them, but there may be a barrier, a genuine barrier, which is not up to us to diagnose as to why they can't take, the most comprehensive option. If they're still engaged with the practice, so two metrics really, do they have a next appointment still booked, whether that be for something for their regular hygiene or maintenance or something that they're now that with you as a new patient, they're going to come in and see, even if they're not taking on board this. That's the number one priority, because it means that even though they haven't picked this option yet, they trust you. They're not wanting to go somewhere else. They just aren't here yet. Okay. The second metric is then the sliding scale in that direction, which is how often do your patients choose the more complex treatment earlier on. So that's the second part of the skill, I guess, in terms of us providing enough, listening well enough and providing what the patient really needs to move towards that decision pathway sooner as well. So I think it's sort of two things. It's, are they still with you? And how often are they then transitioning to the comprehensive solution that then provides you, I guess, a bigger picture of the success.
Mhm. All right, thank you so much. There have been some fantastic insights today. So we've talked about patient psychology, communication, trust, team alignment, treatment planning, follow-up, and now measurement. So right now, we would love to hear from all of you. If you have a question for our panelists, please drop it into the Q&A box or feel free to raise your hand if you'd like to ask you a question live. Right now, we have a question from one of our attendees. Let's get to it. Let's see. All right, so we've got a question from Ashima. She asked how to respond to an anxious patient who is meeting you for the first time and states they don't like the dentist. How can we change the course of talk and make it worthwhile? Dr. Andrew, maybe we could start with you.
Yeah. I think obviously it's something which we deal with quite regularly, and some people find that, quite a confronting position when the first thing you hear is that they don't like the dentist. I think the good thing is, well, it's like, well, look, at this stage, it's the first time we've met, so we're not here to make any judgments up front. We just want to hear, what it is that gave you the courage to actually come into the appointment today, despite whatever experiences you've had. Try and get them to open up and get them to basically just feel relaxed enough to just talk to you. They may hate the dentist, that might be their story, but why, and what is it that's allowed them to overcome that, to at least be in your room that day, and how can we move forward?
Rika or Janet would like to add in their perspective.
Sure. Yeah, I love I love what Andrew said. I think I would use, one of the great phrases I love to use is that feel, felt, found. To be able to say, Mrs. Jones, I know so many of our patients have feel the same way that you do. When they first came to see us, they were very fearful, just like you. And what they found was once they got here, they got to know us and they got comfortable. We've become one big happy family, and I can't wait for that for you as well. What can I do to make your appointment more comfortable? Would you like a blanket? Would you like a bottle of water? Whatever you offer, and just open up that conversation.
Rika, anything you'd like to add, maybe?
No, I think Andrew really he got the line. It's like, you know, when patients say, I don't like the dentist, and like, what gave you the courage to come in today? And I think that's a great question, because you acknowledge their fear. You acknowledge what they feel. You acknowledge them in where they are. And so then they will open up. They will tell you, oh, when I was 6 years old, my father took me to the dentist, and the whole story will come up. I'm just making it up, but I mean, um, you will get to know everything. And then when that's out of the way, then you can move on.
All right, thank you so much. And to everyone who asked questions, we have very little time, so we're going to move on. So before we wrap up, I also want to quickly mention the Dental Member Network. If you enjoyed today's discussion and are looking for ongoing support, resources, and expert guidance, the Dental Member Network is designed specifically for dental practice owners and teams. It includes access to expert insights, valuable resources, live discussions, and additional opportunities to learn from industry leaders. You can scan the QR code on your screen or visit the website for more information. I'm going to give you a moment to scan the QR code. All right. So one final reminder about the complimentary practice growth session. So if today's discussion has highlighted opportunities within your practice and you'd like a personalized look at your growth opportunities, be sure to take advantage of this complimentary $900 session from Equa Marketing. You can scan the QR code on your screen or use the link in the chat to reserve your spot. We really do encourage you to do that before you leave today. In the meantime, I'd like to ask each of our panelists for one final takeaway. If there was one golden rule about trust-based case acceptance that every dental team should remember tomorrow morning, what would it be? Janet, let's start with you, then we'll go to Rika, and Andrew will finish with you.
Ask good open-ended questions and active listen to get to know your patients.
Is it my turn already? Oh my God. I would say meet the patients where they are, and then bring them up where you want them, Like take them with you, but meet them where they are.
Andrew?
Yeah. Look, I guess tying in the few of those themes together, I would say, patients don't need to accept treatment today. They need to understand their situation. So number one is making sure that they understand. Number two would be that the diagnosis doesn't change because of affordability. The pathway might, but the patient needs to accept their pathway. They choose. The diagnosis is the same, then we have the options. And the last part of that is related, is that our job isn't to convince, but it's just simply to provide that clarity. So we need them to understand, we need them to have clarity, and give them the full power to take control of their decision and the outcome that they're after. So by going through all of that, then you're going to find that you do have less patients feeling pressured and patients taking decisions or making decisions that suit them.
All right, thank you so much. As we wrap up today's discussion, one message has come through very clearly. Patients are far more likely to move forward with treatment when they feel informed, respected, understood, and supported throughout the process. Trust isn't built during a single conversation, it's built throughout the entire patient journey, and every member of the team plays a role in that experience. A huge thank you to Janet, Rika, and Andrew for sharing their expertise and insights with us today. And thank you to everyone who joined us live and participated throughout the discussion. And before you leave, please do take a moment to complete the feedback survey that will pop up in your screen right after this webinar ends. Your feedback helps us continue creating valuable conversations like this one. Thank you again for joining us, and we look forward to seeing you at the next Thriving Dentist Expert panel. Have a wonderful evening, everyone. All right. Thank you so much.
Great, thank you.
Thank you so much, all of you.
Thank you. It was absolutely great. Thank you again.
All right.
Nice to meet you all.
Yeah, same thing. Although we'll have to connect. Okay, bye everyone.
You to the US, Andrew?
Pardon?
You come to the United States for conferences?
I do, yeah. I don't have any trips this year, but I believe I'll be back there again next year sometime. So probably every second year I find myself there.
Nice.
So
Well, I'll keep in touch.
Okay.
sounds good. Thank you very much.
Bye everyone. Bye-bye.
Bye.
Bye.
Angie.
Thank you so much. Bye.
Bye-bye.